Thank you everyone for coming to this webinar titled Your Child with Klinefelter Syndrome, What to Expect During Puberty. This is presented by Dr. Ilene Fennoy, who is a member of KS&A's research committee, has been a long-standing member of the board of directors and has stepped down from that role but is still working with us on the research committee. Her profile is featured in the materials provided with this webinar, so I will not reiterate that, but I will tell you that Ilene is one of the most highly respected pediatric endocrinologists in our field, and is going to have a very, very good presentation for you. But before we start the webinar, I wanted to also introduce Karsten Block. Karsten has headed up a group in Texas that has featured a Facebook page that provides help and support for KS&A and for individuals around the world who want to participate in an online dialogue that is based in Facebook. And he also has a support group in Texas. Karsten does a very innovative thing. He runs a support group as a virtual support group using similar tools to this GoToWebinar system that we have. And he conducts virtual support group meetings on a regular basis. And what I'm going to do is I'm going to turn this over to Karsten briefly and allow Karsten to introduce himself and show you a bit about his program and his Facebook page. So Karsten, the floor is yours.
All right, thank you so much. Yeah, as he already mentioned, my name is Karsten Block, and my wife and I started this this group here about 5 years ago. I'll go ahead and take it through my slides here. And basically, what we did back then in June of '07, our son was diagnosed with XXY, Klinefelter syndrome. And honestly, we were completely clueless. We had no idea what we were doing, what we needed to do, and how we could best help our son. The first months, we were given some different help from the States, getting some therapy going, that kind of thing. And after a year of that, we decided that we wanted more help. We wanted to connect with some other parents and understand how other people were doing things, that we didn't want to reinvent the spoon for every single thing that we were trying to do. So in May of '08, I created the website klinefelters.org, and at that time I hadn't figured out it was Klinefelter syndrome. I still thought it was Klinefelters. However, klinefelter.org was already taken, and Klinefelter syndrome was already taken, so I just stuck with klinefelters.org. And right after I did that, I thought, well, Facebook should be a great media for that as well, and I created a group on there. And it's a closed group that enables our members to communicate in private, but still online with other parents and individuals who have Klinefelter syndrome themselves. We started out calling it the Klinefelter support group, Klinefelter syndrome support group Texas. But soon after we started it, we added the and beyond after the name, because we soon had members from other states and as well as Canada. And recently I changed the name again to KS Global Support Group, because we now have members in 14 countries, and I didn't want the Texas to scare them off and think this is not for me. So over the last 5 years, we started out, after 1 year we had 12 members. It was very small. We had conference calls on a regular basis. We try to do it monthly, but it doesn't always happen. After 2 years, we're up to 29 members, 3 years, 48, 4 years, 94. So recently, over the last year or so, year and a half, we've really added a lot of members. We're now up to 144, and this slide deck is about 2 hours old, and we're now up to 146. So it's moving quite rapidly. The relations, for all the members, I don't just add them to our Facebook group. I try to get their information as well. And if there's anybody on this call who has not given their information yet and think that I'm going to share with others, I am not going to share anything with anybody unless I have your written consent. The only thing people can see is if you join the Facebook group, other people in the group can see your name in there. And the reason why I'm collecting this data is so that we can focus our time on creating events that are applicable to you and your situation. So in our group, we currently have 83 parents, so 83 that have a son with KS. We have 23 that have it themselves, and then we have 27 members that we just don't know. We don't have enough information on them. We have one sister who has a brother with KS. We have a cousin with a cousin, and we have a wife with a husband who has, or actually 3 of them, who has Klinefelter syndrome. We have all age groups basically, and the highest number here is actually the missing, and those are the ones where I don't have ages yet. But 5 to 11 years old, we have a lot of those, and I think they'll really benefit from being members of the group because they're about to get into an age where we're looking at testosterone replacement therapy and all that stuff. So I'm really excited to see all this interest in our group. And also here's a quick map showing all the push pin. The red push pins are where we have members currently. So obviously all over the Texas is completely covered pretty much. Northeast we have quite a few, and we have a few in California, and then we have a couple in Canada, a bunch of them in Europe, all over Europe, and we have some in Australia as well. So for future plans, and I promise I'm almost done, our future plans this year, I want to see if we can hit 200 members. So I will be doing a little bit more promotion of the group and of our page. See if we can hit 200 by the end of the year. That will be my goal. And then next year, I think we'll have enough members to really start meeting in person. And obviously, it will make sense to start here in Central Texas. We have probably 30 or 40 people that could potentially make a day trip to meet with us here in Central Texas area. And what I want to do is get a church, hospital, medical clinic, somewhere where we can get in for free, where they have a vested interest or the willingness to let us use a venue for free. The first one will probably be more of a meet and greet. We'll do share some experiences with other parents and other individuals with KS, and I'll try to get some local guest speakers. That could be medical professionals, it could be teachers, it could be a number of different things, depending on what age group we're looking at having at the get-together. And then down the road, hopefully we can start doing some in-person meetings. I know we already have the Tri-States support group up in the Northeast, and I know they're already doing something like this. We'd like to partner with them and let them run them and offer it out to our members as well. So I'm really excited about this, and I see the numbers grow all the time, and it's just really nice to see that so many people are getting something out of this. On the Facebook group, there's a lot of questions and answers. So it's if you're not on there already, I definitely recommend you joining us. The easiest way to do that is go to klinefelters.org and go to contact us and basically register in there, and then I will send you the link. It's already on here, but I would want you to register on the website first so that we have your information, because you'll be seeing other people's names and questions and everything, so I think it's fair that everybody kind of shares a little bit about themselves with me as an organizer, and then I have that data so we can pull some reports, we can look at some of the demographics, and we can understand who we're dealing with and how we can best help them. And as I said, I promised I'll be done soon, so that was my little spiel. Any questions, go ahead and hit the raise your hand button, and I'll let Jim facilitate any questions there are right now. There
was only one about participating in the group, and it was a question about what information would you want to share, and that
Absolutely. So basically what I'm asking for is, actually, can you, I guess, can you still see my screen, everybody? Can you see my screen, Jim? Can you see my web browser?
Let me see here. Yes.
Okay. So on the website, if you go to the Contact Us up in the top right corner, you can click on that link right, or on that button right there, and basically the information that I'm asking for here, you can read through it yourself. Basically just your name, address, name of the individual with KS if it's not yourself, birth year of the individual so that I can do some demographics, your relationship so I know if I'm talking to the mom, dad, or the individual with Klinefelters, and the age where the person has been diagnosed.
Carson,
yeah, and I have one little exercise. My wife just walked up on me here, and she made a good point. We do have some where they, to protect their child's name, we have some that have given a nickname or a different name for their son because they don't necessarily want that name to be out there, and that's the name they use on the Facebook group as well. So they're welcome to do that. They're welcome to not give their last name. I would like to have at least a city and a state for U.S.-based folks.
I'm going to take the screen back and make sure that I have something suitable on display here. And what I would like to do is emphasize something that Karsten has touched on. KS&A has membership, and much like Karsten has a screening process for determining who is actually going to be a participant in his group. We have the same thing because KS&A has a number of forums, and I am going to that screen now to display it for you. KS&A has all these forums, and they're private. And the reason they're private is that people reveal quite a bit about themselves or their children in these discussions. And you can see KS&A has an enormous number of forums broken up by condition. So trisomy X, XYY, and XXY in age stratified groups. We had considerable trouble when we used wide open listserv formats based on Yahoo groups and similar things, where we were infiltrated by spammers and email harvesters, and we even had some less than ethical medical professionals trolling the lists looking for patients, if you believe that. They would actually learn who the individual was and then contact them off the list and start pestering them to make an appointment. So we had enough of that, and we set up a membership initiative that is pretty simple and straightforward and very inexpensive. An annual membership is $25, and if you are wondering why, it's because in order to become a member, we have to go through one of several steps. One is to simply take a payment from you, which is automatically certifying who you are by using a bank account, whether it's a check or a credit card. You have to identify yourself absolutely and unequivocally. And so that tends to filter out all the spammers and the email harvesters and so forth. And we do allow individuals to come in and try membership for 2 weeks with no charge, but in those cases we have to go through very carefully and make sure that the individual is who they claim to be. And we normally check public records and so on to verify the identity of the individual who's trying to sign up. And we regularly get people who attempt to sign up without providing any information, and lo and behold, when we ask them for the information, they are very reluctant to provide it. So they're obviously not legitimate participants in a group that shares personal medical information. So one reason that Karsten's group and KS&A are partnering on this is we wanted to make you aware of Karsten's group and encourage you to participate in both his group and the Facebook group, because face-to-face support group meetings are difficult and expensive. We still have them, but they are not as common as we'd like them to be. This is very reliable, and participation is easy and free for everyone. Finally, KS&A is launching a new initiative of 6 or 7 webinars that are going to be free to members. And one reason that we're doing this webinar free this evening to everyone is to introduce you to that and encourage you to join KS&A. We have a long roster of webinars already produced, and we have more webinars on the way. And this one is an introduction for you, and frankly, one of the best you're going to see. So without further ado, I am going to now stop talking, turn this over to Dr. Fennoy, and begin the webinar in earnest. So Dr. Fennoy, if you're ready, I'm going to give you the screen. Are you ready?
All right. Yes, I'm fine. All right. All right. So I want to talk about Klinefelter syndrome and puberty and what you can look forward to with your sons. One of the things, I've used a lot of medical terminology in here. One, to let you know what we are specifically looking for, but two, because it's hard to describe the changes without using the terms associated with them. The goal, though, is to give you an overview of the patterns of change, both in boys without Klinefelter syndrome and those with. So to get started, I want to discuss a little bit about normal puberty, and the 2 aspects of it that are important to us as endocrinologists are the physical features and the hormonal changes. So the physical exam is a crucial part. We're not just looking at blood levels, although I think sometimes my patients think that's the only thing I'm really interested in is the blood. With boys, there is an expectation that the pre-adolescent looks very similar to an infant or a young child. There's just the testoscrotum, penis are all small, but they're all there, fine, functional. We consider the first stage of puberty enlargement of the testes. The original description said testes and scrotum begin to enlarge with a change in the texture of the scrotal skin. So the endocrinologist is really trying to look and identify these changes. Tanner 3, sort of mid-puberty, the penis is much longer, it's broader, the testes continue to enlarge. Tanner 4, the testes are getting bigger, the scrotal skin gets darker, and Tanner 5, we consider the genitalia to look like the adult. If you notice, these are gradations of change, so bigger, bigger, and biggest. That's the way we do it. We don't have a lot of very concrete measures. Many of you may have seen endocrinologists who have their little beads on the string, the orchidometer, that allows us to be more precise in our measurements. But these are the changes that we are looking for during the physical exam. Pubic hair is considered a separate change from the change in the testes, scrotum, and penis. So pubic hair is almost none at all in the prepubertal individual, and then as you begin puberty, so the first stage, Tanner 2, there's sparse hair, it's long, it's straight or slightly curly. Tanner 3, it's darker, it's coarser. Initially in Tanner 2, it's just at the base of the penis, but Tanner 3, it's beginning to expand over the bony area just above the penis. Tanner 4, the hair is adult in type, but it doesn't extend to the thigh, and Tanner 5, it's adult in type extending to the thigh. In actual fact, the endocrine literature includes a Tanner 6, which most of us do not use in clinical practice, where hair extends up the abdomen, the central portion of the abdomen, and that was considered Tanner 6. So most of us say that the male is mature in terms of pubic hair when they reach Tanner 5. So these stages occur at different ages, and what I've illustrated for you here, the TS stands for Tanner Stage 1, then Tanner Stage 2A, and down here at the bottom you see 2A is the testes are enlarged but there's no pubic hair, versus 2B, there's pubic hair and enlarged testes. And then Tanner 3 to 5 is looking more at the pubic hair changes than at testicular size. And you can see the age span here is anywhere from 11.5 to 15 for all of puberty. So we're saying that boys take about 4 years to go through from beginning to the end of puberty. Testosterone levels are low initially and gradually rise, and Tanner 5 at about 400 is considered an adult value, but the adult range, when you look at lab reports, will say anything from like 350 to 900, 1,000, 1,100. It varies according to the lab. In actual fact, this is one of the problems that many of us have, is that labs are not standardized for these hormone measures. And so if you go from one lab and then use a different lab, the values may differ simply because they did a different way of measuring the testosterone. So many of us get very particular about exactly where and how this blood is being measured when we're trying to follow how a child develops. So what I've described for you now is the change in testosterone levels in normal puberty that you can expect for any boy going through puberty, saying that it begins about age 16, about age 11, and continues till about age 15 on average. But boys, we still say they're normal if they start at 9, and we still say they're normal if they don't start until about 13.5. So puberty can be very wide range in terms of when it occurs in boys. Now let's focus a little bit on the hormonal changes. On the bottom here you have testosterone in the bars, all right, and you can see Tanner 1, the pre-pubertal child, has very low testosterone. Now on my previous slide I shared that Tanner 1 had about an average testosterone of 16, and if you notice on this side it says less than 20. Many of the assays that are designed to measure only adults, the only value they will give you is less than 20 at the low end. And you can't tell whether a boy is having a value of 3, 10, 15, or 20 because their only measure is less than 20. It turns out that if you take your 2-year-old and check testosterone, the level is likely to be about 2 or 3, or maybe lower. So less than 20 is not very discriminating when you say that Tanner 2 is a 16. And these are reasons why your doctors can get very particular about where those testosterone levels are measured and how they're measured. But as you can see, the testosterone gradually rises with each stage of puberty. So these stages represent the physical changes, and these bars are representing the testosterone. And then we have these hormones here, FSH and LH. These are the hormones in the brain that normally stimulate the testis to start developing. So in pre-puberty, the LH and FSH are low, and as the boy matures, the FSH and the LH rise. Okay, so what do we see in boys with Klinefelter syndrome? First, if you look at just growth, these black bars here represent the normal population, and the blue bars here represent the average height of boys with Klinefelter syndrome, and the red lines represent boys going through puberty with Klinefelter syndrome. So this is their average final height. This is their progression through puberty. And even though we know Klinefelter syndrome is associated with tall stature, what you're seeing here is that most of the boys are above the middle range of the population, but they're not giants. They're normal heights. They may be tall for their family, but their heights are in the upper part of the normal, with a few being very tall, and very few of them are in the lower range. So this is typical of Klinefelter. Growth is slightly above average, but not dramatically so. What about their physical pubertal changes? So here we're going back to P standing for pubic hair and G standing for genital stage. And what we're saying here, these are different boys in the squares, circles, diamonds. It's just different individuals. The lines are connecting each individual, and the gray bars in the background represent normal boys at each of these stages of puberty. So Tanner 2, Tanner 3, Tanner 4, Tanner 5. So we have boys starting puberty, or boys prepubertal at 10, having entered the first stage of puberty by 11. We have boys prepubertal at 12, with the first stage of puberty a little bit later, but still at 12. And boys who don't start puberty until 14 to 14 and a half. So we have the full age range in boys with Klinefelter syndrome. And then they are progressing in terms of their pubic hair from Tanner 2 to Tanner 3, whoops, sorry about that, to Tanner 4. And here we have one going to Tanner 5. So pubic hair is changing in these boys with Klinefelter syndrome, just as hair changes in all boys going through normal puberty, right? When you look at genital development, now here we're talking mostly about change in the scrotal skin and change in the penile length. And again, the boys are starting 10, 11 prepubertal, going to Tanner stage 2, a little bit older, Tanner stage 3, 4, and 5. So they are progressing in terms of their genital development almost exactly like the general population. What we do see, however, is the testes themselves are small. So here the upper limit is 4, and 4 is considered the first stage of puberty when we measure testicular size, and normal adult males get to testes about 20. So what we're showing you here for all of these boys is they're not getting very far. Their testes are starting out small, 1 to 2 cc's, and going up to 4 cc's as they go through puberty, despite the fact that they're getting normal pubic hair and normal phallus enlargement. All right, so it's really only the testis that is behaving somewhat differently in the physical development of these boys as they go through puberty. This here is showing you bone age. Again, the gray in the back represents the normal population, and bone age represents an x-ray of the hand in which we're comparing it against children at various ages and saying, okay, 10-year-olds that are boys have bones that look like this, and 12-year-olds have bones that look like this. Your child compares to this population of 12-year-olds that we looked at and studied in the past, and your child's bone age looks the same. Your child is 12, it looks the same as all these other 12-year-olds. Or you can have a child who's 10, and your child's bones look like those of a 12-year-old. Or you can have a child who's 10 and their bones look like those of an 8-year-old. So bones do not have to look the same age as the patient's actual age. And so we look at bone age because individuals who don't get testosterone tend to have bone ages that are younger than their actual ages as they go through puberty, and people who get testosterone too early may have bone ages that are older than their actual ages. So it's a way of our getting another piece of information about whether the child's development is progressing appropriate for their chronologic age. And here for the boys with Klinefelter syndrome, they're progressing just the way the general population is. So on a physical basis, boys with Klinefelter syndrome, as they go through puberty, are not demonstrating major differences in terms of their pubertal or genital pubic hair type development. The major difference is testicular size. So this is sort of a summary. This was done in 1991. The slides I showed you were actually from populations more recently, and this has held up. Mean height for boys with Klinefelter syndrome is about 79th percentile. Well, 50th percentile is average, 95th percentile is way above average. So boys in general are in the upper normal, but upper normal. Mean weight is about 50th percentile, which means their weights are average. Mean head circumference is 40th percentile, again, close to average. In terms of their endocrine reproductive function, they are entering puberty normally. The penis is normal in size and develops normally. What is striking is that the testes are small, but frequently they develop a little bit and then stop. So here I'm showing you now a little bit more of the hormonal. We've talked a lot about the physical and compared boys with Klinefelter to the general population and shown they're very similar in terms of physical features. Now, in terms of hormonal features, the gray boxes in the background represent normal population without Klinefelter syndrome, whereas the boxes, the dark boxes and the open circles and squares and triangles all represent individuals with Klinefelter syndrome. We have the T stands for testosterone. We're using the European measures here, so the numbers don't correspond to what your physician usually looks at. The estradiol is what the E2 stands for, so estrogen measurement. People have worried a lot about whether your boys have excess estrogen or inappropriate estrogen. And then the bottom C graph is estrogen in relationship to testosterone, because another way of looking at it is maybe the estrogen isn't high, but the testosterone is low, so the balance between them is abnormal. So this was an attempt to characterize the sex hormones, testosterone and estradiol, and the ratio between them compared to the general population in these gray boxes in the background here. And as you can see, for the young boys, 10 to 12, their testosterone levels are low and correspond to the general population, although you see some boys starting puberty with elevated testosterone in the 11 age group. The testosterone levels, though, in the individuals with Klinefelter syndrome do begin to rise. Here we have some boys rising at about 12 and others rising 13, 14. So the testosterone levels are rising just the way you expect them to rise in the individuals without Klinefelter syndrome. The little squares or diamonds or circles in red are individuals who had the gonadotropins LH elevated. Remember 2 slides back or 3 slides back, whatever, I mentioned that the gonadotropins were the hormones from the brain that stimulated the testis and told it to produce testosterone. Well, when the testis is not doing as well as we'd like it, usually the LH and FSH begin to rise. So here we are looking at the individuals who have the high LH and FSH versus the individuals in the open and black boxes who have normal LH and FSH, and we're just looking at their testosterone values. And what you're seeing is the individuals with the high LH and FSH tend to have somewhat higher testosterone, but their testosterone values are in the normal range for the general population. So it's as if their body is working hard to produce that testosterone, but it's succeeding. All right. Estradiol here in the boys with Klinefelter is in the same range as the population without Klinefelter. So the gray boxes are in the same area that these dark triangles and squares and open circles are. And when you look at the ratio, there are a few individuals who have elevated estrogen testosterone ratios, but most of the boys have the relationship between the female hormone estrogen and the male hormone testosterone being normal. And particularly the boys with the elevated LH-FSH, they have perfectly normal ratios. So there's no evidence that the testosterone itself is inadequate from this point of view. Now, this is an example of a patient of mine, just to show you what happens in any one patient. So at age 10, this individual had prepubertal gonadotropins, the LH and FSH from the brain, were in the normal range for a child who has not yet gone into puberty. The testes were small, like you expect in a prepubertal child, so his Tanner stage would be for genitalia 1 and pubic hair 1, 1 being prepubertal. And the testosterone level itself was 7.6 nanograms per deciliter, so that's in the prepubertal range. All of these values are what you could expect to see in a 1-year-old or a 10-year-old. It would make no difference. This is what you expect to see in a child who has not entered puberty. So the child then, a year and a half later, well, almost 2 years later, is beginning to show some changes in the genitalia. So we're now at Tanner 2 genitalia, but no pubic hair yet. The testes have enlarged. They are now 4 cc volume, which is what we see at the earliest sign of puberty as far as the testes are concerned. And we see that his hormones from the brain, LH and FSH, are now in the pubertal range. They're at the low end of the pubertal range, but they're in there. And the testosterone is 72 nanograms per deciliter. So it is elevated. This is not prepubertal anymore. It's definite evidence of testosterone production. By 12 and a half, still no pubic hair. The testes aren't any different, but the gonadotropins, the pituitary hormones are higher and the testosterone is higher. And then by 13, the physical exam has progressed further, so there's enlargement of the phallus. The pubic hair has begun to develop. The testes, again, have not increased in size, but now we're beginning to see abnormal gonadotropins. So LH, FSH are elevated. They are no longer in the normal range, but our testosterone level is 431. Sorry, I left the space out there, so it might be a little bit hard to see. But this is 431. This is a normal adult value of testosterone. So at 13 years, this child, despite the elevated gonadotropins, which say the body has to work twice as hard as anybody else to get there, is able to produce normal adult amounts of testosterone. All right, let's divert for a minute away from the hormones and the genital development and look at breast enlargement. So that's what gynecomastia is. And just a few words about gynecomastia in general. It's really common. It is not exclusive to Klinefelter syndrome. This was a study of individuals in the Greek army, so everybody who enlisted, and they randomly sampled, so they looked at nearly 1,000 males, and 40% of them had gynecomastia, so increased breast size. And the most common association was excess weight, okay? They also saw that boys with earlier pubertal maturation also seemed to be more likely, so boys who started puberty earlier. There was no association with testicular size, all right, in this one. And now these are not boys with Klinefelter. These are just everybody coming in to enlist in the Greek army, which was mandatory conscription, and this is what they find. 40% of them have some breast enlargement. This was a study in the U.S. looking at boys 10 to 16 years of age at a Boy Scout camp, and they looked at 1,890 boys. 38.7% of them had breast enlargement. About 20% of the boys had some breast enlargement at age 10 and a half. 64% of the boys had breast enlargement at 14 and a half, and then by 15, only about 10% had it. So it seemed to be a part of normal pubertal development that increases as they go through puberty, but then as they get towards the end of puberty, it regresses. So this gynecomastia is to be expected in a large percentage of boys as a part of normal pubertal development. In Klinefelter syndrome, attempts have been made to identify was there any difference in this pattern, and this is from older data, 1991, where they were tracking individuals with Klinefelter syndrome, and it's a small number, but they had 36% of 14 boys over the age of 13 had some gynecomastia. When they looked at 100 boys, or 94 boys without Klinefelter syndrome, 31 of them had gynecomastia, so 33% of individuals had it. So the 33 versus the 36 is no real difference. So gynecomastia is present as a part of normal puberty in 30 to 40% of boys, and it's to be expected. Attempts to correlate it with testosterone were able to show that the testosterone in all these boys was normal till approximately age 14. In this particular group, there tended to be some drop in testosterone after age 14, but the gynecomastia was occurring before age 14. So it did not seem to be related to testosterone. And then this was another study that looked at 18-year-olds to see whether there was gynecomastia related to the hormone levels, and they looked at boys who had gynecomastia versus boys who did not. And estrogen levels were higher in the boys without the breast development, not significantly, but the trend suggested if there was going to be a difference, you'd have to say the values were towards the boys who didn't have it. In general, we would say from mathematical and statistical analysis that these are the same. When you looked at testosterone levels, there was a slight difference, but with higher testosterone levels in the boys without gynecomastia. And when you looked at the estrogen and testosterone ratio down here, it was the same. There was no measurable difference between the two. So it's not clear what is causing the gynecomastia. It appears to be a part of the normal pubertal development, and it doesn't clearly seem to be related to testosterone levels. So gynecomastia is no more common in KS than in the general population, and obesity is the most common association with the increased breast tissue. So probably keeping healthy weights is the best prevention for breast enlargement. Okay, so from a physical point of view, the boys are developing pretty much similar. Their major difference is testicular size. Now what about their ability to think and function and their social adaptation? The kinds of traits that we're going to talk a little bit about are things that make them vulnerable to maladaptation, their overall intellectual functioning, executive functioning, verbal memory, language, autism, sorry I misspelled that, spectrum disorder, and neurodevelopmental outcomes and testosterone. So those are the topics I want to cover. These are the kinds of traits that are associated with social maladaptation: social withdrawal, social anxiety, shyness, impulsivity, depressed adaptive skills, communication difficulties, unassertiveness, emotion regulation problems, and difficulty in reading social skills. So how much of this you have, any combination of these you have, can make you much more vulnerable to not functioning well socially. What about the intellectual functioning domain? Number of studies have looked at it. The best studies initially were back in 1991, where they were following groups of children over time, and were able to demonstrate that in terms of verbal IQ, there was a slight difference in the boys with Klinefelter syndrome. So if we say normal IQ is 100, the control population had an average IQ of 98. The boys with Klinefelter had 85. When you looked at performance IQ, the control population had an IQ of 101. The boys with Klinefelter 94. So they were slightly different, and the P-level over here is identifying that this value and the variation around it is significantly different from this value and the variation around it. So they were slightly lower, but these are still in the normal functioning range. So intellectual ability may be minimally compromised. When you look at another full-scale IQ test that was done in 2012 by Sophie van Rijn in the Netherlands, the individuals with Klinefelters had an overall IQ of about 80, whereas her control population had an overall IQ of about 97. Again, slight difference, slightly lower in the Klinefelter population, but not, they were still in the normal range. This was another test looking at cognition by Judy Ross. She was looking at younger children, and she was looking at verbal skills. So this differential ability scales looked at verbal skills, their ability to use words, understand words, and express words, spatial skills, their nonverbal reasoning, and then a composite of all three of these. And when they did that, they were able to demonstrate that the boys with Klinefelter syndrome functioned better under age 10 than over age 10 for verbal skills and nonverbal skills and spatial, so that the overall functioning suggested that function was better at the younger age group than at the older age group. They used the wide range achievement test, which is another test schools use, psychologists use to look at overall functioning. And these are boys coming to, these are boys under the age of 14, in which she's looking at cognition. And using this test, again, the boys under 10 did much better with reading compared to the boys over 10, but the difference with spelling and math was not significant. So that reading skills clearly seem to be a much greater problem for the older boy, and may explain some of the differences that we were seeing here with the differential ability scales, although this suggested that there might be some nonverbal as well as spatial problems in individuals over 10. All right, so cognition seems to be a little bit lower, but still in the basic normal range. What about executive function?
Dr. Fennoy? I have several questions that are backed up here, but this one is context sensitive, so I'll interrupt here. If you go back one slide or two slides, Bill has a question about the scales on the left of the screen, especially I think on the next one. Are they indexed against 100 or what?
Yes, they're indexed against 100. So 100 would be average performance. So these boys are performing less in the lower end of average. Okay, yeah, the lower end of average. Like 90 to 110 is considered the average range on IQ scales. So these boys are functioning about 90 under 10, and then a little bit below that in the over 10 group.
Okay, I think that was
question?
Good. I have several questions that are more about interaction with doctors and medical exams and so forth. These might wait for the end. Yep. Or later at least.
Yeah, I think they may wait for the end. Let's just finish the neurocognitive at this point, okay?
Go ahead.
Okay. So let me get back to executive function. This is what people use when they're in new situations and unfamiliar circumstances. So things like strategic planning, inhibition, like stopping yourself from doing things you know that are going to get you into trouble, words that you might say that are going to get you into trouble, or other behaviors that we all sometimes feel like having but don't do. Focused and sustained attention, so how well can you do that? organized search. You need to figure out how to get something done. So how do you organize yourself? I guess I don't want my Google Calendar. Flexibility of thought and action. How quickly can you change from one situation into another? Monitoring, and then what's called cognitive flexibility, which is, stopping to pay attention from one thing and switching to another, and choosing between two alternatives. Example of poor cognitive flexibility would be rigid or repetitive behavior in new situations. So you get a new situation and you do what you always did, even though this situation is totally different. Okay, so that defines the kinds of things that people are looking for when they are trying to assess executive function. And one particular test that Sophie van Rijn from the Netherlands has used, has been used in a lot of other site groups as well. It's called the Wisconsin card sorting test, where cards are organized by numbers and letters, and they change the way they present them to you, and you have to sort them. You have to recognize that you're no longer looking at the number order, but now looking at the letter order, and therefore change your sorting pattern accordingly. So it's a test of your ability to be flexible with this cognitive information about numbers and letters and whatever's on the cards. Basically what they were showing is that the boys with Klinefelter had more what they called perseverative errors. So if you presented them the cards with numbers, and the numbers, and they sorted them in numbers, when you suggested the letters, they would still try to sort them in the number format, even though you're now faced with letters. They wanted to do it the way they had already done it. They kept doing it the same way over and over again, whereas the population without Klinefelters did not make those kinds of errors as often. Both groups are making the errors. It's just how often you're making it. And when you looked at the errors that are made that are not repetitive errors, they're similar between the groups. So this is suggesting that the boys with Klinefelters needed to do the things in the same way over and over again. They were reluctant to change and adjust for a change in the situation. Another measure of executive function would be sustained attention and inhibitory control. Judy Ross used two different tests to look at this, and basically she was able to show that children under 10 usually just forgot things. They omitted things. So when they tried to do things rapidly, they omitted doing things. They couldn't keep their attention on them long enough to keep them in mind. But when they were older, there was no difference in the types of errors that boys with Klinefelters made compared to the general population. And then when they did a word interference test, again, no difference between the control group and the boys that had Klinefelters. So there were just types of errors that are made more often in different age groups by individuals with Klinefelter syndrome, but many of the things are very similar between boys with Klinefelters and without. Verbal memory, the performance was less than the control group, but we were talking about average performance or low normal or average to low average on a variety of different tests. So they're not performing very poorly, they're just performing low average. Language was a problem. In general, language was more than one standard deviation below the normal. And the biggest problem was with expression. They could interpret things, but they had trouble expressing things. And then there's this whole issue about autism and autism spectrum disorder.
Dr. Fennoy?
And yeah.
I have a question about executive function.
Yeah.
It's a practical question. Is there any kind of training or preparation or intervention that might help the boys improve their executive function capabilities in some sort of a proactive way?
That's not totally resolved. I'm not an expert in these developmental tests, but in general, working with individuals that are experienced in this area in the neurodevelopmental seems to make a big difference for some individuals. But this is not an area that has been systematically done, and because these errors are at the executive function level rather than the more basic levels, they frequently are not identified until late in the child's development, which may be part of our problem. And so I've had boys frequently evaluated by individuals who are not experienced with Klinefelter, and they keep telling the parents everything is fine when the parents know that there are these kinds of perseverating errors. So one of our tricks is to get more of our psychologists very attuned to these problems so that they work on developing tools for the individuals. I've seen some psychologists be very successful with children, but I don't know how much that was because of their tools or their interaction with their patients or their willingness to explore new ways of working with an individual and not just the traditional. So this is the difficult part for the families. They really have to investigate developmental pediatricians and psychologists and try and identify places to go. Dr. Taglia at Denver has been really at the forefront of identifying these, and so she's a good contact person to find out if there's somebody in your area that could be helpful.
We also have a webinar coming up in the next couple months, probably sooner actually, focused on executive function issues, and I'll be announcing that soon.
Okay, and we may all find out more about ways we can be helpful and helping these young men deal with these issues. Sometimes just changing the environment and the level of expectation allows them to work it through and move to the next stage. But this is an area of active investigation that's not completely clear yet. So now onto autism and autism spectrum disorder. Autism has become very popular recently. And it's a little bit hard to define, but the best one that I have identified is to say that this is a group of symptoms of atypical or abnormal development of the immature brain. And what you're looking at is social problems, so impaired sociability, inability to empathize, or read the mood of others. And so they get into impaired or inappropriate social interactions. Rigidity and perseveration, the need for sameness and the resistance to change, and impaired language. So these three areas, the impaired sociability, the rigidity and perseveration, and the impaired language, are considered the characteristic three parts of autism. But patients may also have problems with executive function, memory, sensory issues, attention, mood, affect issues, responsiveness, motor and cognition problems, and those are not considered key elements of the definition of autism. Okay, so many of the boys seem to be more in these combination issues rather than in the autistic features, although they may have some of them. The autism definition seems to apply to the extreme of the impaired sociability, rigidity, perseveration, and impaired language, with the autism spectrum disorder applying to the broad category of a variable extent of any of these three, and Asperger's syndrome being sort of the high-functioning individual with some aspects of these three characteristics. So autism spectrum disorder really encompasses the whole range of it, and Asperger's is sort of high-functioning, and autism in its severest form is the most disabling. So attempts have been done to define whether Klinefelter syndrome really does have autism or autistic spectrum disorder, and there's an autism spectrum questionnaire, and multiple different articles actually have looked at this. These two here are both from Sophie Van Rijn looking at young adults. And basically, when they answer the questionnaire, Klinefelter versus a group that does not have Klinefelter, there are higher scores, so more autistic spectrum features in the group with Klinefelter recognized by the black bars compared to the control group. So boys with or young adults with Klinefelters answer the questionnaire in a way that indicates they have more of the features of autism than the group without. But clearly there's overlap, which is part of the issue with Klinefelter syndrome. It's very broad in its presentation. When you look at the individual skills like social skills, attention switching, attention to detail, communication problems, and imagination, which are part of these key features of autism, the control population has fewer autistic traits than the Klinefelter population in the black bars for each category of problem. Okay. However, nobody yet in any of these studies has been able to demonstrate that those who received testosterone had a different response than those who did not. So we are left with these features seem to be present. They are variable to the extent to which they're present, but they do not seem to be influenced, as far as we can tell, by testosterone treatment. In our study and attempts to look at boys with Klinefelter, we looked at 43 patients, 16 of whom were prepubertal and 27 pubertal. And we observed that none of these boys in the prepubertal group met criteria for psychiatric diagnoses. Okay. On the other hand, 9 of the 27 pubertal children had a psychiatric diagnosis of some type. So these issues of language, executive functioning, autistic types traits, all of these things seem to be emerging as features that are more easily recognized and causing the boys problems as they get into the pubertal age group. Our review suggested that there were more behavioral and learning problems in the pubertal group compared to the prepubertal group, that their major issue in terms of quality of life that was a problem was quality of life at school, not quality of life anyplace else, but quality of life at school was decreased in the pubertal group compared to the prepubertal group. and that when you gave them the pediatric quality of life test that evaluated their assessment of their own quality of life, the score was associated with age, showing that the older you got, the lower your assessment of your quality of life. And the only time that testosterone seemed to be important in this contribution was when the testosterone level was inappropriate for the physical stage of development. But when the testosterone was appropriate for the child's physical stage of development, there wasn't any difference in their quality of life, their scores compared to the other children. So puberty does seem to be a period of time where the psychosocial problems become a bigger issue for boys with Klinefelter syndrome. So what do we conclude? That really boys physically have a pretty normal pubertal onset, and with a normal rise in testosterone at least till mid to late puberty, and maybe longer. Nobody has really tracked it to be sure where and when. All right, but normal onset is definitely what's happening at the beginning. That overall their intellectual function is somewhat decreased compared to their sibs, but it is not severely disturbed. So this is not mental retardation, right? And behavioral and psychosocial problems are common throughout both childhood and adolescence and adult life. They're extremely variable in severity, but reading seems to be the performance that declines with pubertal age as far as we have been able to assess. And that this issue about autism spectrum disorder is common but variable, again, in extent and severity, and it's definitely persistent into adult life. The quality of life in the school environment is the most problematic for the pubertal child. It's not a problem for the prepubertal, and we do not at this point have evidence that testosterone treatment has any bearing on these behavioral psychosocial features unless testosterone is inappropriate for stage of development. So finally, our social executive function skills as represented by the autistic spectrum disorder are present. Impaired sociability, rigidity and perseveration, impaired language. They are there, but again, variable. But they appear to represent a greater problem for the adolescent than the younger child. And one of our speculations would be that probably because, one, these are pretty mild in individuals with KS, and to some extent the sociability, the empathy issues are things the lack of ability to handle those are things we expect as a society of a very normal child. We don't have major expectations that a young child is going to be very empathetic with another individual. That's something we expect to teach them and experience. But as they get older, we expect them to develop that skill. And so for the adolescent with Klinefelter, if they're not really showing that progress, then we have that as a problem for them, even though they may have been showing the same problem all along. And testosterone treatment doesn't seem to affect any of these issues. So testosterone doesn't seem to be the answer for this. There are reasons for wanting to look at testosterone. One, you want to ensure that puberty does progress normally, but the expectation is that physically and hormonally it's going to start and get to mid-puberty by itself without any need to do anything. And then two, if it fails or doesn't start, the only way you're going to know is because you looked. And then For the person who does have deficient testosterone, then there seems to be even greater distress in terms of quality of life and social skills. So you're not going to find that unless you're monitoring. So those are reasons that the fact that you have normal puberty does not mean that you don't want to start assessing your child and making sure that they're progressing normally. So that's the end of the descriptions that I have, and I'm happy to take questions.
Okay. I have several backed up here, and excuse me that I'm not going to take them in order, but I am going to focus on some of the more clinical ones first. Okay. Is there anything special about a KS boy who's gone into puberty early versus a typical boy who has entered early puberty? How important is it to seek out a specialist versus a general pediatric endocrinologist for an assessment for early puberty?
The only concern about early puberty is the real concern about whether it's truly precocious or not. We define normal puberty as beginning anywhere from 9 to 14 in a boy. So a 9-year-old who enters puberty and just gets to what I described as that Tanner 2 stage with a little enlargement of the genitalia, no pubic hair, that kind of change is considered normal, just early normal. And that in and of itself is not considered pathology or that one needs to intervene. And with Klinefelter syndrome, the expectation is they're going to have normal puberty, and 9 to 14 is the age range, so if they start at 9, that's early normal. Now, for boys who actually start puberty before 9, there is a lot of concern that there may be pathology. And it's well described in the endocrine literature that half of all boys who have truly precocious puberty, so the onset of puberty before age 9, really have pathological, so they have disease. There's something really wrong in 50% of them. With Klinefelter syndrome, the concern is there is an increased incidence of germ cell tumors, so tumors of the reproductive organs that produce hormones. So that would be a real worry if you see a boy with Klinefelters developing prior to age 9. But in the 9 to 14-year-old early normal, so 9-10 versus 11-12, that would not be a concern. Okay, so this mom responds, started probably 7.5 to 8 years old, hit Tanner 2B by 9th birthday. So sort of on the precocious end? Right. So, I mean, one of the things, I didn't go into the discussion of the variations of pubertal development, but one of the variations is you get pubic hair and you don't get anything else. In other words, the penis doesn't get large, the testes don't start enlarging, you don't get changing in the scrotal skin per se, you really just get pubic hair, which we call pubarchy or adrenarchy. That occurs in 40% of normal children. And it's not true precocious puberty. So in that, I mean, we can see that in Klinefelters as well. Those we work up. We do check to make sure there is nothing wrong with them. But in general, there is nothing wrong with them. And I would not necessarily expect a particular problem, but I would definitely work it up, so the patient should see an endocrinologist, but an endocrinologist, a pediatric endocrinologist should be working up adrenarchy in very young children. That's all. Okay, so working my way through here. How does pubertal testosterone therapy impact sperm production, assuming that there are sperm? Okay, fertility question. You're right. That is an unknown issue. the concern on the one hand is that testosterone given by injection, by patches, by tablets, by gels, whatever, will feed back and suppress the brain's gonadotropins, and that will suppress any tendency for the testis to make the testosterone itself, because you're replacing its function. So it doesn't need to function anymore. That may suppress sperm production if there are any sperm being made, and certainly testosterone therapy has been proposed as one form of male contraception, just for that reason. So how much testosterone and how you use it can have an impact on the ability of the testis to make sperm, whether you have Klinefelters or not, right? So I currently caution parents that we don't know yet what the proper thing is to do to maintain fertility to the extent that we can in adolescent boys with Klinefelter syndrome, right? Really, the data on the fertility has all come from adults. None of it has come from pediatric patients. And you're trying to find a sperm, and you're trying to then preserve it for an unknown number of years with the hopes of fertility. So there are a lot of unknowns with all of that, because the whole idea of preserving sperm is relatively new in the great scheme of things, right? And the adult population from which we have demonstrated the ability for some men to have, with Klinefelters, to have families, that population didn't need to save sperm for a prolonged period of time. So you're introducing multiple different levels of elements in here with the hope of fertility, for which we have no information. So I mean, I just think people need to be aware of how limited our knowledge is before they knock themselves out in trying to get the sperm. In most cases, the sperm was taken by extraction, so a surgical extraction from the testis, not from ejaculate. So in the men where it was successful, so you know, you have to ask, are you ready to do that with your child, to try and find some sperm to freeze to hope for the future? So I mean, I just think there's a lot of things we don't know, and the sperm count is definitely low. So how invasive you want to be in adolescence is a big question.
Okay. One mom has been very patient here as I've put her off. Michelle has asked several questions, and the first is her son is embarrassed about physical examination. He's just about 13 years old and is very, he's developing, he has pubic hair and so forth. He's very reluctant to let the doctor examine him. How do you handle that?
Okay. I reassure boys they're normal for being embarrassed. That most of us are embarrassed about these type of exams, so they aren't any different than all the rest of us. They are still necessary exams. So I try to elicit their cooperation by making a part of the routine. A lot depends on how you do it, and I mean the goal as far as I'm concerned is to be as efficient as possible, but also to make it a part of the exam, not an isolated event. Here, come in, you're just doing this. And that seems to go pretty well for most of the individuals. Occasionally there is somebody who is really just too afraid, and then it becomes an issue of how important is it to do it. And as long as I'm not really worried about a tumor, I may let it go, but I very seldom have to do that. I mean, once or two times in a long number of years I've had to do that, but most times I can get cooperation of the individual.
Okay, following up, several people have asked questions in this realm about the physical exam and the sorts of testing for LH, FSH, and testo levels and so forth. How frequent should that be for a kid in puberty, and with the variability from one doctor to another? How persistent should a parent be about making sure that their child is getting fairly intensive scrutiny in these areas?
I think the big issue is life is a lot simpler if you have good physical exams that you can follow. All right, and that gets back to the other mother's question for the child who's very embarrassed. The goal is to convince the child that this is a part of what we have to do. We all have to do it. End of story. We just go on. We do this. We get over it. We go on to the next thing. The blood testing, I think, is variable. I do it during development in 6 to 12 month periods until I feel they're pretty far along, and then I might go back to once a year because we don't know when to expect the testosterone to fall. I'm evaluating when I want to add testosterone therapy. Some doctors choose just arbitrarily put everybody on testosterone at age 13, and that's an unknown question what that does and what it doesn't do. Dr. Tartaglia has an ongoing study now where she's looking at developmental issues and hormonal issues in a group that is randomized to get testosterone early on versus a group that doesn't get it early on in puberty. Ultimately, they all do, but at the beginning, she's changing who gets it early and who gets it late. But we really don't know yet. We're looking a little bit more at bone and body fat and measures of cardiovascular risk, like too much fat in your stomach, and how that affects your risk for diabetes and heart disease and cholesterol and triglycerides and those kinds of things, because testosterone affects all of that. To see if we can come up with a medical indication that you need it. Certainly if you had osteoporosis or if you had problems with your muscles, you might need it. So it requires some screening. I recommend at least annually for the more mature boy to make sure that you're staying in the adult range. But usually as they get in the 10 to 14 range, I'm doing 6 to 12 months, depending on how they're progressing, to see whether they're actually going to go through puberty and actually going to get to the adult range. And I don't see any good way of getting around doing those tests, but it's not set in stone yet, and we don't have clear guidelines in this area because we don't know what the appropriate time to treat is and what to treat with. So you can be as insistent as you feel it's important to you and your family. The big question for the child is where in puberty are they, and is the testosterone rising? I don't think you can get that very clearly unless you do at least once a year in the pubertal years, and then you want to know, is it staying up there, because the testis may fail, and you're not going to find that out unless you serially check. So once a year would be my minimum, and every 6 months would probably be my maximum.
Okay, this mom asks about the fact that it appeared from the presentation that puberty gets off the ground pretty well early on, and then appears to possibly slow down. And she asks, when does testosterone slow down after puberty?
That's unresolved. That's the reason why I'm saying that you need probably annual follow-up for testosterone measurements after you are thought to be physically mature, because some people it may stay up, some people it may drop, and there's no way to know which group is which from our current information.
Okay. Another topic, and several have asked questions on this, so I'm going to try to synthesize. They're asking about normal muscle development versus a typical boy, and overall physical fitness and capacity for physical fitness, and outcomes, likely outcomes for things like weight training and gymnastics and so on.
There's not a whole lot of information on this. Certainly, I do not recommend testosterone is a hormone that stimulates muscle development, all right? However, I would not recommend it for a pre-pubertal child to stimulate muscle development. Klinefelter's is a condition in which muscles are described as hypotonic, so poor tone, and boys don't tend to be terribly interested in athletics, although I certainly do have some very athletic boys with Klinefelter syndrome. But as a group, they tend to be more shy and stay away from it, and described frequently as clumsy. But what to do about that besides physical therapy and more sports and involving them in all sorts of physical activities is not known. Judy Ross in Philadelphia has just completed a study in which she used oxandrolone, which is a weak androgen, in boys in the 4 to 10-year-old group. Now, oxandrolone is an androgen that is in a pill form as opposed to injectable or cream or gels, that kind of thing. It's not as potent in terms of making hair on your body and more male-type, virilizing-type features as testosterone, and hence has been used in low doses in girls as well as boys, because sex hormones like testosterone increase your ability to grow in height. So they are used as growth stimulants as well as muscle builders. And she has demonstrated, at least as reported at the last endocrine meetings, that that there was increased muscle mass and decreased body fat in these boys who received the oxandrolone, and they seem to have better physical capacity. This is the first report of this. and I don't think anybody knows what to do with that, and how important or not important it is, and this becomes a major issue when you start talking about sports and using hormones to change muscles, because frequently this is an area banned as the boys get older. This is considered abusive to use sex hormones to give you increased muscle capacity. So it's a gray area that does seem to be able to make some difference to the boys, but I'm not sure people are ready to use it routinely. I don't know anybody who's prescribed it to any boy with Klinefelter syndrome outside of Judy's study. So that's where we are with using sex hormones to enhance their muscles.
A couple of questions on comorbid conditions. One's a little more extensive about dental issues and I guess orthodontism, and the other just a question, is there a correlation with scoliosis? But first, I guess the dental question.
I mean, orthodontism is more common in Klinefelter syndrome than in general, and so the dentist really needs to be aware of the Klinefelter syndrome, and so that they make a point of looking and are sensitive to it. But in terms of scoliosis, scoliosis is a common problem for rapidly growing individuals. Okay, so you see it occurring at puberty in all children, and particularly those growing the most rapid. So I don't know anything more specific about scoliosis and Klinefelter. I've never seen anything specifically highlighting scoliosis as being a bigger problem for Klinefelter than you would expect from any other rapidly growing boy. And since Klinefelters tend to grow early, starting about age 6, their growth velocity goes up prior to puberty. It can occur anywhere from that age on up, just as a function of the change in growth rates.
The question on dental issues also just included a question about whether or not there are any delays in dental development that are associated with KS.
I'm not aware of any delays as a routine part of KS, but that is not an area that I have spent a lot of time reading about, so I may be in error there, but I'm not aware of any.
Okay, the questions are coming so quickly here, it's hard to stay on top of them. Excessive sweating, is there any correlation with excessive sweating?
Not as a general problem. I mean, it's seen with unusually high testosterone. So if somebody was overdosing themselves on testosterone, that may be an issue. It's seen with other medical conditions like overactive, underactive thyroid. There's been association with autoimmune illness in Klinefelter syndrome, but not so much in the younger kids and adolescents, but throughout life, so mostly described in terms of the adult. But you see autoimmune diseases emerging at puberty in general. Autoimmune thyroid disease might be associated with sweating. So there's possibilities of other things going on associated with sweating, and some people just are heavy sweaters and there's nothing going on with them, and it can be socially incapacitating to be an excessive sweater, and there are clinics now that do nothing but deal with the excessive sweating, hyperhidrosis, because people can be sweating so much they can't shake hands. I mean, I had a 10-year-old girl in my practice who did not have Klinefelter. She was a girl for sure. She didn't have any illness, except she was shorter than she wanted to be, but no medical illness. But she would not she walked around with her hands over her chest, clutching her chest because she was sweating so much she didn't want anybody to ever touch her hands. And we had to get her treated because she just could not socially interact with people with the degree of sweating. So it requires some kind of evaluation to be sure there's no other medical problem, but it's not inherently a part of Klinefelter.
I want to pause for a moment and just give you the opportunity to come up for air, and you let us know when you've reached the end of the line here. I do have other questions.
Okay, I have about 9 more minutes.
Okay.
How's that?
All right. Well, I'll try to scoot through these quickly. In terms of late onset puberty, the use of growth hormone and the use of growth hormone to stimulate growth. Do you see any concerns about that in those who have KS?
No, but I mean, we don't usually use growth hormone for late onset puberty. I have had patients with growth hormone deficiency and Klinefelter syndrome, and they were short, right? And they were short prepubitally. They were not, it wasn't delayed puberty, they were just short and not growing. And that's usually the context in which growth hormone is used. Since Klinefelter syndrome is usually tall, there's usually not confusion about delayed puberty as a function of growth hormone deficiency, and people focus on other issues as a cause of the delayed puberty that need to be ruled out. So I would not expect that in general boys with Klinefelter syndrome would be receiving growth hormone.
Okay. Another comorbid condition, pectus excavatum. How is that related?
It's been described. It's unclear to what extent it is present, but it certainly is described as a feature seen, but it's seen in the general population as well. In and of itself, it's usually not a problem unless it is so severe to compromise the chest space so that the heart and lungs don't have enough space, and it can be that severe. But in general, most children don't have that problem, so it's an incidental finding on physical exam that doesn't require any intervention.
A mom asks about, let's see here, catching up. In other words, if the testosterone levels have started to decline, is there any way with testosterone therapy or otherwise to catch back up to start developing at a normal rate?
Well, in general, when the testo starts to decline in Klinefelter, you already have reached adult physical maturation, so there's no need to catch up on a physical basis. And in terms of the testosterone itself, then you give medication to provide adequate serum levels of testosterone. The goal is that individuals should have a normal sexual libido and not have problems with osteoporosis or excessive body fat or muscle wasting from testosterone deficiency. But there isn't really a need for catch-up. It's replacement for that which is missing.
Okay, the questions are actually slowing down now. Dyslexia.
What about dyslexia? I mean, language is a problem in Klinefelter syndrome. It's present early on. So boys with Klinefelter need attention to language training. boys in general have more dyslexia than girls, okay? It's the way of the world for whatever reason. Girls develop slightly earlier than boys. It seems to be just true. When you know you have Klinefelter syndrome, you know that they are definitely at risk for language issues. And so you just want to make sure that you have you get the school to provide extra support, that you provide extra support, because it is a problem for the boys. But most of the boys that I've seen with support, and a lot of parents, that's the approach they've taken. Give them extra tutoring and support, and the kids are staying right along, doing well. Some of them college preparatory program, some of them regular class, but they're staying along and performing and identifying the things they like to do and doing them fine. And when you realize that 66% of all individuals with Klinefelter syndrome are probably never diagnosed, or at least half are never diagnosed, these problems can be managed, and boys without Klinefelter syndrome learn how to manage them. So the approach is, this is manageable, and you convince the child it's manageable, and you provide the support to make it manageable. In most cases, that works quite well. There's always an exception.
In an effort to wrap up here, I'm going to touch on 3 things, and these will be the last of it. The first is, does testosterone therapy help psychosocial educational issues? I think you touched on this, but just...
At this point, we have no evidence that it does, unless a person is deficient. All right, so if you bring me an 18-year-old who should be physiologically mature and tell me that his testosterone is down around 100, which is what I would expect at the beginning of puberty, all right, they may suffer depression, weakness, and other problems associated with that low testosterone, which will make them function better psychosocially and physically if I replace them into the normal level. On the other hand, that same 18-year-old who is making 400 or 500 nanograms per deciliter of testosterone on his own will not need testosterone to raise him to a higher level to get any improvement in his psychosocial, because he's not deficient. So it really seems to be an issue of the deficient state, and the problem you have in puberty is, how do you define deficiency when you have a moving target from a low level to a higher level? What is the measure of deficiency? And at the moment, we don't have that clearly worked out. So follow and demonstrating that the child's testosterone is getting higher and higher is reassuring that their testes are functioning and they're able to make testosterone and they're not deficient.
The last technical question is about sleep. I think some of the adults with KS tend to have sleep disorders such as sleep apnea and so forth, perhaps related to weight. This mom, though, asks about sleep disorders in teens, and in her case, she's describing excessive sleep.
Right. I have seen that described a lot by families and patients. I don't know of any studies that have really looked at it in Klinefelter syndrome. There is alteration in the sleep-wake cycle in adolescents. Adolescents tend to stay up at night and sleep during the day, and that is a normal characteristic pattern of the adolescent, despite the fact that we managed to get them to go to school for the most part through high school and college, despite their desire to rearrange the day. But I don't know any studies that have actually evaluated the excessive sleepiness. My anecdotal experience, and it's not from study at all, is that testosterone treatment in the patients that I've given it, because there was a question of maybe it was lower or not, but it was borderline, so let's see if raising it up made a difference. That did not make any difference in their sleep patterns. So I have not been convinced on an anecdotal basis that testosterone had any impact on there, but I have not seen any studies that actually looked at
it. The last question is really a request. Bill asked that we get our hands on the reference material that you used to produce this. It was an enormous amount of praise, by the way, coming in the question and answer line. There's a lot of praise coming in as well, so I have to reiterate that praise, how good this has been. And Bill is eager to read some of this source material that you cited. Can we work together to gather that up and make that available to the extent that it is available online?
Yes.
All right. Thank you.
That's fine.
I
mean, I've identified the references on the slides for this, so I mean, you know, we can create a bibliography and see what we can do to get it available to you.
All right. Well, I want to thank you profusely for this was an outstanding webinar. This was very, very detailed, but easy to understand. I'm extremely happy with how clear this was and how informative. So thank you very much, and thank you for being part of KS&A's advisors on research and so forth. This is tremendous, and you are a tremendous resource. Thank you.
Thank you.
This is Carson Block, and I would definitely second that. I really appreciate it. There was a lot of really good information in this, and well prepared. And I want to thank Jim as well for including us in this. And I look forward to many more great webinars. And I've gotten some great ideas for our group as well, just for how to manage these things logistically. So I really appreciate it. Thank you, both of you.
Thank you.
Thank you, everyone. Good night.
Good night.